slides తీస్తాయినా? So first we will see what are the learning objectives for today's lecture. At the end of the lecture, you should be able to understand the extent of the problem and types of nutritional anemia. You should be able to enumerate sources, functions, inhibitors, promoters for iron absorption. You should be able to give recommended dose, recommended allowance for iron, recommended daily allowance for iron. Then you should be able to enumerate deficiency manifestations of iron. And the last learning objective is you should be explain the activities of National Program for Control of Anemia in India. So we'll go for the magnitude of problem. In world, this is a major public health problem of world. Half of the world's population is suffering from anemia. More than 3/4 of all preschool children are anemic, and 1/3 of all children of school-going age are anemic, while 70% of women are anemic. Out of this, most of the population belongs to Southeast Asia region, or majority is formed by Indian population and the population from Southeast Asia region. Now we'll see the Indian scenario of anemia. It is a severe public health problem. We call it as severe because the prevalence of anemia in India is more than 40%, and it affects the vulnerable population, that is children and women of reproductive age group. And the prevalence among non-pregnant mothers is about 50%, or 50% of non-pregnant women are anemic, while 70% of pregnant women in our country are anemic. Same is the condition with the children. 70% of the children below 5 years are anemic. Then this reduces the work capacity of the individuals from our country, and in turn reduces social and economic productivity of the country. And recently it has been found that even men suffer from anemia. The men below the age of 20 years and men above the age of 40 years, they also get anemia, and 40% of Indian men do have anemia. Now it said ki nutritional anemia. When we say nutritional anemia, it can be caused because of deficiency of 3 nutrients, and those are iron deficiency, folate deficiency, and B12 deficiency. Even protein deficiency can indirectly give rise to anemia, because for transporting iron, transferrin, which is protein, is required for the transportation of iron. So protein also indirectly is responsible for causation of nutritional anemia. All these deficiencies can be corrected by giving supplementation of these nutrients. Out of these causes, the commonest cause for anemia is iron deficiency. So iron in human body, 3 to 4 grams of iron is present in our body. 60 to 70% of this is in the blood in the form of hemoglobin. 1 to 1.5 gram is as storage iron, which is stored in bone marrow, spleen, and in kidney. And each gram of our hemoglobin contains about 3.34 milligrams of iron. And there is photograph of one green leaf vegetable. This is spinach. And in bad old days, we used to think that spinach is the richest source of iron. It contains iron, but many other green leaf vegetables are also good source of iron, like amaranth, fenugreek leaves, radish leaves. These are also good sources of iron. So remember, not only spinach but even other green leaf vegetables are good sources of iron. Then we'll see the functions of this iron. Iron, the most important function of iron is it is required for formation of hemoglobin. Then it is required for development of brain. It is also required for regulation of body temperature. It is required for muscle activity and for maintaining the immunity. Then it is component of myoglobin, the cytochromes, catalase, and the certain enzymes. But the main and the central function is oxygen transport and cell respiration. Now in this slide also again I have shown you one photograph of green leaf vegetable, and that is amaranth. There are different varieties of different species of amaranth, red and green. This is also a good source of iron for those who are vegetarian. Now we'll see the sources. What are sources for iron? The sources of iron are broadly classified into heme sources and non-heme sources. The heme sources is the good source of iron because it is better absorbed. The iron which we get from liver, meat, poultry, fish are the example of heme sources of iron. But egg is poor because it contains phosphates in it which interferes with the iron absorption. It is good source, but phosphates in eggs, they interfere with the iron absorption. So remember, liver, meat, poultry, fish are good sources of heme iron. Now we'll see what are non-heme sources. The iron which we get from cereals, green leafy vegetables, legumes, nuts, oilseeds, jaggery and dry fruits are the examples of non-heme source of iron. But the bioavailability of iron which we get from these sources is very poor because of presence of inhibitors in the non-heme sources. We'll see in detail which are those inhibitors and which foods contain those inhibitors in later slides. Now we'll see absorption, from where the iron is absorbed, in what form it is absorbed, how much it is absorbed, and what factors which factors influence the absorption of iron. First we will see in what form it is absorbed. Iron is absorbed in ferrous form. So from ferric form to it is converted to ferrous form in presence of vitamin C. So vitamin C reduces ferric iron to ferrous iron and it becomes easy for absorption. The iron is absorbed from the duodenum and upper small intestine. So if there is any disease of this part of intestine, iron absorption is hampered. Like celiac disease, tropical sprue, in these diseases iron absorption is hampered. Then the factors which influence iron absorption are iron reserve. If iron reserves are depleted or are exhausted, the iron absorption is fast. Then it depends on the presence of inhibitors which are present in Indian vegetarian diet, which interfere. And in next slide I will tell you the inhibitors and which are the inhibitors. And the promoter, so vitamin C and the foods which are rich in ascorbic acid promote the absorption of iron. And the last point for absorption, which is very important, is only 5% of the iron is absorbed from the Indian diet. So to get 5%, you have to give 100 grams. If you give 100 milligrams, if you give, then only 5 milligrams will be absorbed. Now in this slide I have shown the sprouted pulse. So sprouting improves the nutritive value of the pulse by increasing the vitamin C and B group of vitamins in it. As C vitamin is increased, it helps the absorption of iron from that pulse. Now these are the factors which influence iron absorption in our body. First is iron reserve. So whenever there is depletion, exhaustion of iron in our body, absorption is faster. Inhibitors. So inhibitors are present in Indian diet, like phytates are present in bran, the phosphates are present in egg, calcium is present in milk, the oxalates are present in green leafy vegetables, tannin is present in tea, and even turmeric also inhibits the absorption of iron. So these things inhibit the absorption of iron. Now we'll see promoters. I told you vitamin C and foods which are rich in ascorbic acid, they promote the iron absorption by converting the ferric iron to ferrous iron. Then diseases of duodenum and jejunum also interfere with the absorption of the iron. Then the fifth point which influences the iron absorption is demand. So whenever there is increased demand of iron, the iron absorption increases. Examples are during pregnancy, iron demand is increased. During growth, iron demand. So for children, when they are growing, the demand for iron increases, so absorption also increases during that period. Now this is the slide to show iron cycle in the body. So iron is absorbed from lumen in the ferrous form and is transported to the tissues and is stored in the ferritin form and transported with the transferrin. Now we'll see how the iron is lost from the body, how much amount, and what are the causes for loss of iron from our body. Daily in males 1 milligram of iron is lost, while for females 2 milligram is the daily loss of iron. This increased loss is there in females because of menstruation. So menstruation is responsible for 12.5 milligrams of extra loss of iron. Then hemorrhage is responsible for loss of iron. Hemorrhage can be of two types, physiological or pathological. So hemorrhage, which is because of childbirth and menses, is the example of physiological blood loss. While pathological blood loss can be because of peptic ulcers, it can be because of hemorrhoids, it can be because of malaria, it can be because of hookworm infestation. So these are the pathological causes of hemorrhage. Basal loss occurs through the sweat and through the urine. So minimal amount is lost through the basal loss. And one more cause for the iron loss is intrauterine device. So intrauterine device is responsible, or it gives rise to the blood loss. And if the mother is anemic, for her, advise her or insert the progesterone, the hormonal intrauterine device, which causes less, or it reduces blood loss by about 15%. So that was about iron loss. Now we'll see what are different stages of iron deficiency anemia. So iron deficiency anemia presents in the form of 3 stages. First is the decreased storage of iron. Here there is depletion of iron storage, iron store, and the individual may not have signs symptoms of iron deficiency. The second stage is of latent iron deficiency. Here there are no signs symptoms, but if you do investigations like serum ferritin and transferrin saturation, the values are reduced in this case. So most of the individuals are in this stage, but the hemoglobin level in this stage might be normal, but serum ferritin and serum transferrin saturation are reduced in this, and this stage is because of exhaustion of iron stores. The third stage is of overt iron deficiency. Here there are signs, symptoms of iron deficiency, and if you do hemoglobin estimation, that is also reduced in this stage, at this stage. So that was about stages of iron deficiency. So majority of the cases belong to latent stage of iron deficiency. Now we'll see what are the normal values for labeling, what is the normal value for hemoglobin, and what are the cutoffs for labeling person as anemic. So normal hemoglobin level in blood, which is considered as normal, is 14 grams per 100 ml or deciliter. WHO cutoffs for criteria for anemia for adult male is, the man is considered as anemic if his hemoglobin level is less than 13 grams per deciliter. For females and for adult woman who is non-pregnant, for her the cutoff value is 12 grams per deciliter. So for non-pregnant women it is 12 grams. For pregnant mothers it is 11 grams, because there is hemodilution in case of during pregnancy, so the cutoff is 11 grams. For children who are above 6 years, the cutoff value is 12 grams. If his hemoglobin is less than 12 grams, then you label him as anemic. For children below 6 years, the cutoff value is 11 grams. So nutritional anemia is health problem, a social problem, and an economic problem in our country. So now we'll see what are the investigations which are done for the evaluation of iron status. So routinely done investigation for estimation of or for diagnosing the case of anemia is hemoglobin concentration. Then you can go for MCHC, and which should be above 34%. If it is less than 34, then it indicates that there is hypochromia. There is hypochromia of red blood cells. Then serum iron concentration should be in the range of 0.8 to 1.8 milligram per liter. If it is less than 0.5 milligram, then that suggests that the iron stores are depleted. Then serum iron concentration should be about 10 micrograms per liter. Now this serum ferritin is the most sensitive indicator when you are identifying cases of anemia in the community where the prevalence of anemia is low. For there this is the best investigation, or you can say this is the sensitive indicator for identifying cases of anemia in the communities where the prevalence is low. Then serum transferrin saturation should be above 16. Normal is 13%, but it should be above 16%. If it is less than 16, then it suggests that it is iron deficiency anemia. Slide change होता है. So we will go for iron requirement now. What is the iron requirement? And here this iron requirement is given according to the sex and according to the physiological condition of the individual. So for adult male, the requirement of iron is about 0.84 milligrams per day. And I told you only 5% of iron is absorbed. So for getting that amount, you need to give him 17 milligrams per day. So recommended daily allowance of iron for male is 17 milligrams per day, but the requirement is 0.84. Now we'll see what is the requirement for adult female. For adult female, the requirement is 1.65 milligrams per day. For getting this amount, her recommended daily allowance is 21 milligram per day. Now we'll see what is the requirement of pregnant woman, and this is very important because this nutrient you can't fulfill the requirement of pregnant woman just by improving her diet. You need to give her prophylactic doses during pregnancy because requirement is very high during pregnancy. So requirement during pregnancy is 2.8 milligram per day. For getting that amount, she needs to get, or her recommended daily allowance is 35 milligrams per day. We'll see what is the requirement during lactation. Here for during lactation, the requirement is not increased. It is same like that of non-pregnant mother, which is 1.65 milligram per day. But as most of the women, many women in our country are anemic, so we continue with the prophylactic dose of iron and folic acid even after delivery. And to fulfill the requirement, she requires her recommended daily allowance is 21 milligram per day. So that was regarding the iron requirement per day. And I have highlighted the point, and that is requirement during pregnancy, because this is important for MCQ point of view. The requirement is 2.8, and for recommended daily allowance during pregnancy is 35 milligram per day. I will see clinical features. Now in community medicine, you won't get question on clinical features, but for identifying or for suspecting patients who are having anemia, for that you need to know how they manifest. General appearance. Now when you see general appearance of the person, he looks pale. The person is with poor built and nourishment, because along with anemia he might have protein energy malnutrition and other deficiencies, and he is easily fatigability, or there is easy fatigability among him because there is reduced work capacity because of anemia. Then in headache, he may have a complaint of headache and giddiness. Face looks pale and puffy, Eyes, in eyes, the conjunctiva looks pale, hairs look dry and lustreless, tongue is pale and smooth, abdomen may have anorexia and acidity. Then thorax, in respiratory system, he may complain of breathlessness. Cvs system, he may have soft systolic murmurs which are best heard over pulmonary area. If you record his BP, might be low than normal. Pulse is rapid and weak, and feet are edematous. If you examine the nail of the individual, they appear, there is cholinachia, which is spoon-shaped nails, and edema of face, feet with or without ascites indicates hypoproteinemia. And this is the photograph of nail with spoon shape or cholinachia. So this is again one of the signs of anemia. Now these are the symptoms of anemia. Centrally, he may have fatigue, dizziness and fainting, blood vessels, low blood pressure, skin may appear pale, cold, yellowy, respiratory system, in that he may have shortness of breath, muscular system, he may have weakness, and in heart he may have palpitations, rapid heart rate, chest pain, angina. So these are some of the symptoms of anemia. So if these signs and symptoms are there, suspect of anemia, think of common things first. So for examination, so where you should examine and which are commonly examined sites for the pallor. You see, for palpebral conjunctiva for paleness, for pallor. You see for tongue and nails for pallor. And if woman has applied nail paint, or if she has consumed pan, and if she is having conjunctiva, one more site you can see for anemia, and that is vaginal mucosa, because this is common during pregnancy. When you are doing the per vaginal examination, you can also see for the vaginal mucosa for pallor. So these are the sites where you can see for pallor. Now we'll see what are the cutoff points for suggested by WHO to assess the magnitude of iron deficiency anemia. So first column is of prevalence, second column is how you label that problem, third problem is of countries which are having that problem, and the fourth column, in that I have shown the states which are having that problem. So prevalence, if prevalence is less than 5%, then that is considered as, or the anemia is not a problem in that country. And only two places are there, Chile and USA. They are not having anemia as a problem because the prevalence is less than 5%. Now if the prevalence is between 5 to 15%, then you consider that problem as the problem with low magnitude. And Australia and UK are in this range. Then third range is the prevalence between 15 to 40 or 39.9. If prevalence is in this range, then you consider that as a moderate problem with moderate magnitude. And Japan, China, Middle East, these are the countries which are where the problem is of moderate magnitude. And in our country, only few states are there where the problem is in the range of 15 to 40%. So the examples are Goa, Kerala, Mizoram, Delhi and Manipur. These are the only 5 states who are having prevalence less than 40%. Other all states in our country are having prevalence more than 40%. So it is labeled as the problem with high magnitude. So it is a major public health problem in our country. So prevalence is more than 40%. And regarding countries, India, Southeast Asia region and African countries, Africa. So these contribute to most of the population who are anemic. So that was regarding the WHO cutoffs. Now this is the slide showing the normal blood film or peripheral smear. So this is how the RBCs appear when the hemoglobin is when there is no anemia. This is the film of microcytic anemia. So this is the peripheral smear how RBCs appear when there is iron deficiency anemia. And this is to show you magnified RBCs. So here it shows the hypochromia. So microcytic hypochromia type of anemia you get in iron deficiency anemia, and this you can see in the peripheral smear when you do peripheral smear. Now we'll see what is nutritional anemia and what is definition of nutritional anemia. It is condition in which the hemoglobin content of blood is lower than the normal as the result of deficiency of one or more nutrients like B12, folic acid, but especially or commonest is iron deficiency. It is often associated with malnutrition and with chronic infections. Along with that, you may have even other deficiencies like protein energy, malnutrition, calorie deficiency, protein deficiency, or chronic infections like malaria, hookworm infestation. Most vulnerable group is infant, children, and women in our country. Now, most of the times you get question on give epidemiology of nutritional anemia. So if you get that type of question, you answer your question in under these following headings like agent, host, and environment. So for agent for nutritional anemia are iron, folic acid, and B12. So you tell about what is the requirement, what are the sources from where you can get this agents like iron, folic acid, and B12. Then are the host factors. In host factor you describe the age, which age is affected, which sex is affected, in which occupation it is common, which infections are responsible, and the socio-economic conditions if they are responsible. Then environment, here you can tell about cooking practices, food prejudices, like some of the population doesn't have green leafy vegetables, pure vegetarians, in them B12 deficiency is common, and infections. So you describe the problem under these headings for epidemiology. Now we'll see what is the etiology, and there are four main causes for the this iron deficiency anemia. So this is for iron deficiency anemia. So first cause for iron deficiency anemia is inadequate intake of iron. This can be because of poor diet, this can be because of ignorance, or it can be because of ignorance and poor diet. And the second cause is poor absorption and the bioavailability of iron. So I told you that Indian diet there is poor bioavailability of iron. Only 5% of iron is absorbed. So we need to tell people about how to include promoters in the diet and what things should be included in the diet, like mixing the non-heme foods with heme foods, because non-heme iron enhances the absorption of heme iron, enhances the absorption of non-heme iron. So these changes you need to make. Then excessive loss of iron, and this is because of too many deliveries, menstrual problems, this peptic ulcers, hemorrhoids, and the hookworm infestation. These are responsible for excessive loss of iron. Then increased demand of iron is during the growing phase and during pregnancy. So here you need to take care of mothers who are pregnant, prescribe them the prophylactic doses of iron. Now we'll go for prevention and control of iron deficiency anemia. So first is you should start with the breastfeeding. The breastfeeding is the best for preventing anemia for first 6 months of life for the infant during first 6 months. Now milk is the poor source of iron. human milk contains about 0.4 to 0.5 milligrams of iron, and that is sufficient for the baby for 6 months. If baby is exclusively breastfed, he gets the required amount of, and he should not suffer from iron deficiency anemia if he is exclusively breastfed. The problem of anemia starts when you start weaning the child. So care should be taken while you are feeding, and so care should be taken for proper feeding of child, and complementary feeding should be done, and appropriate feeding should be done for the child. Then about dietary modifications, you need to give advice regarding dietary modifications to avoid the inhibitors. The first one is to avoid the inhibitors in diet. Like phytates can be avoided by proper cooking of the pulses. Then sprouting will increase or enhance the nutritive value of pulse. So the iron which we get from pulse will be increased, or the absorption will be enhanced. Then one should not consume tea after meals because tannin interferes with the absorption of iron. Then you should not take milk along with iron. Like if you are advising mother iron tablets, ask her not to take it iron tablets with milk, because calcium in milk will interfere with the absorption of iron. Even turmeric, they say turmeric, it interferes with the absorption of iron. So these things should be avoided in the diet, and include more of iron rich foods, iron rich vegetables, iron rich fruits in the diet. So these are the modifications which you can do to enhance the absorption of iron. Then deworming. So deworming, this is done to prevent anemia because of worm infestations and because of hookworm infestation, especially because of hookworm infestation. So every year in our country they observe National Deworming Day on 10th February and on 10th of August. This was started in 2015 for children in the age group 1 to 19 years. So to begin with, it was only for children from 1 year to 19 years, but now they have broadened this even to the other vulnerable groups like women of reproductive age group, pregnant mothers, lactating mothers. Now here biannually they are giving this deworming, they are doing biannually, but if prevalence is less than 20%, there you can do annual deworming. But in our country, in most of the states, the prevalence is more than 20%, so we are going for biannual deworming. Then control of infection, here the infections which are responsible for causing iron or which precipitate iron is malaria infection and hookworm infestation. So you should take care of preventing this, like using, they should not walk barefoot, proper disposal of sewage can be done, and breeding places for mosquitoes should be eliminated for controlling the infection from the malaria, infection of malaria and of hookworm infestation. Supplementation, so for this I will tell you in detail about how the supplementation of iron is done in our country, what is the dose, how it is given. Then iron fortification, now they are coming with iron fortification. So all nutritional programs which we are having, in that they say ki iron fortified, iron and folic acid fortified food should be used. So in ICDS program and in school meal programs, they are using iron and folic acid fortified foods. Especially in ICDS program, they are using fortified foods. Then health education, to tell them about using safe and wholesome water, using sanitary latrines, preventing infections. So all these, and dietary modifications. So all these should be included when you are giving health education from preventing anemia. Now we'll go for how to do early diagnosis and treatment of anemia. I will not go in detail about treatment part, but earlier I will be telling what you need to treat the anemia. Now for early diagnosis, proper history is required. So if the person is giving history of headache, giddiness, fatigue, loss of appetite, think of anemia and do investigation of anemia. Then you can diagnose by looking at the clinical signs, like for seeing of pallor you can see, and on that you can find out who is having. Then after that you can go for lab investigations such as hemoglobin percentage, peripheral smear, stool examination for OVA and cysts. So these are the three commonly done investigations for the diagnosis of anemia. If it is not getting corrected by giving treatment, then you go for special investigations like serum ferritin, transferrin saturation, because all these facilities are not available at in the rural areas. So these investigations are routinely done for the diagnosis of anemia. Then you can do grading and decide the treatment for anemia. If the person's hemoglobin is in the range of 14 to 11 grams, it is considered as normal and nothing is required. So you don't need to treat him, but here you can give only nutritional advice and health education. For those who are having the hemoglobin level in the range of 11 to 9 grams, it is considered as mild anemia and oral iron therapy can be started for them. Then those who are having hemoglobin in the range of 9 to 7 grams, it is considered as moderate anemia, and here you need to give injectable iron therapy. And if the hemoglobin is less than 7 grams, it is considered as severe anemia and you require blood transfusion for these cases. If you give blood transfusion, that increases hemoglobin by about 1 gram. So this is what was about how to do early diagnosis of anemia. Now we'll go for national program. What program we are having for controlling anemia in our country? For the first time, the program was launched in 1970, and the name of the program was National Nutritional Anemia Prophylaxis Program. For this program, there were only 2 beneficiaries, and that was pregnant mothers and children below 12 years. All the pregnant women under this program, all the pregnant women were given 100 tablets of iron and folic acid, which were having dose of 60 milligram of elemental iron and 500 micrograms of folic acid. And for children, only those who were anemic were given iron and folic acid supplementation. And the dose for children was 20 milligrams of iron and 500 micrograms of folic acid. So only 2 beneficiaries were there under this program. Then they introduced one more program, and that was 12 into 12 years by 2012 initiative, which was for children who are of 12 years. So the child of 12 years should have hemoglobin of 12 years by 2012. So that was the initiative which was launched in 2005. Then the third beneficiary was added to this program, and the name of the program was Weekly Iron and Folic Acid Supplementation Program. This was for adolescent, because that time they realized that anemia is also a problem of adolescent, and most of the adolescent girls are going to be, in near future they are going to be mothers. So it is better to correct anemia during adolescence, and this program was introduced in 2012. So in this, they were giving weekly iron and folic acid to all adolescents who are in the age group 10 years to 19 years in the schools and the colleges which were government aided schools and colleges. And those who were out of school, they used to receive it from the Anganwadis. Now in 2013, they added a few more beneficiaries to that program, and the name of the program was National Iron Plus Initiative. So they widened the scope of this program, and 6 different beneficiaries were introduced under this program. I will not go in detail of that program. I will just tell what changes they have made in the recent program which we are having and which was introduced in 2018. So recently in 2018, the government of India has launched Anemia Mukt Bharat campaign with 6 into 6 by 6 initiative. So I will tell you in detail about what is the 6 by 6 by 6 initiative. So in short, about what is this Anemia Mukt Bharat. The reduction of anemia is one of the important objectives of Poshan Abhiyan, which was launched in March 2018. Complying with the targets of Poshan Abhiyan and national nutrition strategies set by Niti Aayog, the Anemia Mukt Bharat strategy has been designed to reduce prevalence of anemia by 3 percentage points per year among children, adolescents, women in reproductive age group, that is age group 15 to 49 years, and between the year 2018 to 2020. So by 2020 we want to reach this target. Now we'll see what is this 6. So they have 6 beneficiaries. 6 by 6 by 6 initiative means we have 6 beneficiaries. There are 6 interventions and there are 6 institutional mechanisms for reaching these 6 beneficiaries. Approximately 450 million beneficiaries, that is nearly 50% of the country's population, will be reached under this program. Now we'll see who are the beneficiaries under this program. So 6 beneficiaries I said. The first beneficiary is the child in the age group 6 months to 59 months. So they have excluded the babies below 6 months because if they are breastfed, if exclusively breastfed, there is no reason for them to develop anemia. Then children between 5 to 10 years, that is one group. Adolescent girls and boys in the age group 10 to 19 years. Then the fourth group is of women in the reproductive age group, that is between 15 years to 49 years age group. Then is the group of pregnant women, and the last group is of lactating mothers. We will see what are the services which they are going to cover under this program. So these are the services which, or you may say interventions, which they are going to have to control anemia. Prophylactic iron and folic acid supplementation, that is one intervention. Second intervention is deworming of all these beneficiaries. Now they have included all these beneficiaries for deworming. Then intensified year-round behavior change communication campaign, solid body, smart mind, and this includes ensuring delayed cord clamping. They say cord clamping should be delayed by about 3 minutes. By doing this, 80 ml of blood is drawn to the baby's side and he gets extra 15 milligrams of iron, which will prevent him from developing anemia. So this is also one of the initiatives. So 3 minutes. Remember, cord clamping should be delayed for 3 minutes. Then the fourth initiative is testing of anemia using digital methods, and point of care treatment should be given. Fifth intervention is mandatory provision of iron and folic acid fortified foods in public health programs, like the food which is given in the midday meal programs and in the ICDS program. They should use iron and folic acid fortified foods. And the sixth intervention is addressing non-nutritional causes of anemia, because many other causes are also there for causing anemia in endemic pockets, which patients focus on malaria, hemoglobinopathies, and even fluorosis. So nowadays they say even fluorosis is responsible, indirectly it is responsible for causing anemia. It interferes with the absorption of iron. It causes the damage of the damages the mucosa of the intestine and interferes with the absorption of iron. So these are the 6 interventions. So that is the meaning of 6 beneficiaries, and these are the 6 interventions. So target, I told you कि every year they want to reduce the anemia prevalence by 3% in all these 6 beneficiaries. So no need to remember all these figures. Remember, by 3% they want to reduce anemia problem in all these beneficiaries. This is very important one. This chart is very important because every year in NEET exam you get question related to this slide. Now 6 beneficiaries. First one is the age group 6 years, 6 months to 59 months. For them the intervention is, they give, for preventing anemia, they give 20 milligrams of iron and 100 micrograms of folic acid. So this is available in syrup form and the dose is 1 ml for the child who is less than 5 years. Dose is given bi-weekly. The bottle which contains this syrup is of 50 ml and 1 ml is given to the child. The dose is bi-weekly. And regarding deworming, for the children who are less than 1 year, deworming is not done. So remember, again I am repeating, deworming is not done for children who are less than 1 year, or for infants deworming is not done. And the deworming which is done for the child between 12 months to 24 months, for him the dose is half the tablet, that is 200 milligrams of albendazole. Now we'll go to second beneficiary, which is 5 years to 10 years. For children between 5 years to 10 years. For them the dose is 45 milligrams of iron and 400 micrograms of folic acid. This is given on weekly basis, and the tablet, and it is available in tablet form, and the color of the tablet is pink, because sometimes you may get even visual questions and they might show you these pink tablets and they might ask you question. So pink tablets are for children who are in the age group 5 to 10 years. Regarding deworming, the drug given is albendazole. Dose is 400 milligrams and it is given biannually for children who are between 5 to 10 years. Then the third beneficiary is the adolescent who is in the age group 10 to 19 years. For him, the prophylactic dose is 60 milligrams of iron and 500 micrograms of folic acid. This is also given weekly, and the color of the tablet is blue, neeli goli. So blue tablet is there for the adolescents and it is given on weekly basis. So the adolescents should receive about total 52 tablets in 1 year duration, because there are total 52 weeks. So on an average they should receive 52 tablets of iron and folic acid. Deworming for them is also biannually. Dose is same 400 milligrams, single dose albendazole. Now the fourth and fifth beneficiary is pregnant and lactating women. For them the dose is 60 milligram of iron and 500 micrograms of folic acid. Now here I would like to highlight, now they have reduced dose. Under anemia prophylaxis program, the dose was 100 milligrams. Now they have reduced dose to 60 milligrams. So that change is there. So if you get MCQ on what is the iron content of the tablet which is given to pregnant women, so it is 60 milligrams iron and 500 micrograms of folic acid. So these are given for about 180 days and it should be started from the second trimester. It is not given during first trimester because iron is thought to be teratogenic and it is not tolerated, and the requirement is also not that high during first trimester. So you start it from second trimester of pregnancy, and total, irrespective of hemoglobin status, she should receive 180 tablets during pregnancy. So second and third trimester, and there are total 180 days for second and third trimester. Then deworming, now they have introduced this for the pregnant mother, and deworming is done with single dose of albendazole, which is of 400 milligrams, and this should be preferably given during second trimester. So remember, this is new addition in the program. So for pregnant mothers, they do deworming during second trimester. Then is lactating mothers, we continue with the iron and folic acid tablets for the mothers who are lactating after delivery. We start it and you have to continue it for 180 days. For 180 days you continue with iron and folic acid tablets for the lactating mother. So for next 6 months she will get the iron and folic acid. Then the sixth beneficiary is women in the reproductive age group, and the dose for them is 60 milligram of iron and 500 micrograms of folic acid. This is given on weekly basis and the color of the tablet is red. So the tablets which are given to pregnant mothers, lactating mother, and for the women of the reproductive age group are red in color, while those which we give to the adolescent girls is of blue color, because the stigma attached to it, or the adolescent girls, they may not take, because they will think that these are the tablets to be given to the pregnant mothers, so they may not take it. So the color is different but the dose is the same, remember this thing. Then deworming for this beneficiary or for this age group is done biannually, and for pregnant mother it is only done once during pregnancy. So this is very important chart. I have put it in a tabular form to know who are the beneficiaries, what is the dose, how often the dose is given, and how the deworming is done, what is the dose, to which age group it is given. Again I am repeating, it is not, deworming is not done for children who are less than 1 year. For children who are in the age group 12 months to 24 months, for them the dose is 200 milligrams or half tablet of albendazole. For other age groups it is same dose, and that is 400 milligrams of albendazole. Now I will tell you some MCQ which appeared in NEET exams. So there are 20 MCQs which appeared. This time I am showing you the questions. In next lecture I will prepare Google form, and that I will post in the WhatsApp group. So first MCQ, we'll see the MCQ. Best test to detect iron deficiency in community with low prevalence is. For this the answer is serum ferritin. It is not serum transferrin or serum iron or hemoglobin, but it is serum ferritin. An adult pregnant female is termed anemic if hemoglobin is. So there is hemodilution, and cutoff level for the pregnant mother for labeling her as anemic is 11 grams per deciliter. So remember this. Then the third MCQ is, which one of the following pulse has the highest content of iron in it? So the options are Bengal gram, black gram, red gram, and soybean. So here the right answer is soybean. So is the richest among pulses. Soybean is the richest source of iron. Next to soybean is horse gram. Next to that is Bengal gram. Then the fifth MCQ is, iron absorption from habitual Indian diet is approximately 5%, 15 to 20%, 40 to 50%, 70 to 80%. So for this the answer is less than 5% of iron is absorbed from the habitual Indian diet. Then lowest iron content is present in milk, liver, meat, fish. So lowest amount of iron is there in milk. But here remember, breast milk contains 0.4 to 0.5 milligram of iron, and that is sufficient for the babies who are on breastfed. But cow's milk, if baby is fed on cow's milk, then cow's or goat milk, if he is fed on, then he is likely to develop iron deficiency anemia. Oral iron pills, 6th MCQ, oral iron pills or iron injection must be taken along with. So when you are given iron orally, always it should be combined with vitamin C. So options are vitamin A, vitamin C, essential fatty acid or high dose of vitamin D. So here the answer is vitamin C. So you give vitamin C with the iron and you know it enhances the iron absorption. 7th MCQ is iron is maximum in, and they have the options are pista, cashew nut, milk. So here the right option is pista. The richest source among nuts is pista. It contains about 14 milligrams of iron in 100 grams of pista. Here I would like to tell even pumpkin seeds are good sources or rich source, or we may say richest source of iron than even pista. Poor man's iron source is, 8th MCQ, poor man's iron source is almond, grapes, soya and jaggery. So here it is jaggery. So here jaggery is prepared in iron vessel. So iron gets added to jaggery and it becomes good source, and it is good source for iron for poor people. Cooking in iron vessels also adds iron to the cooking or to the food. Now 9th MCQ, which of the following trace element cannot be completely supplemented by diet during pregnancy? And options are iron, calcium, zinc and magnesium. So out of that it is iron. So during pregnancy you need to give iron and folic acid supplementation to the mother. Improvement in diet is not going to fulfill her requirements. Then 10th MCQ is dates are rich sources of calcium, iron, vitamin C and keratin. So the answer is iron. So dates are rich source of iron. Patient has, 11th MCQ, patient has microcytic anemia, least likely diagnosis is. Here you get microcytic anemia in iron deficiency, thalassemia, sideroblastic anemia. So the option or the answer is B12 deficiency, because there you get macrocytic anemia. 12th MCQ, nutritional iron plus initiative includes bi-weekly supplementation of iron and folic acid to 6 to 60 months of age, bi-weekly supplementation of iron and folic acid to pregnant and lactating mothers, bi-weekly supplementation of iron and folic acid to adolescent girls. All of the above are part of initiative. Here the right answer is bi-weekly supplementation of iron and folic acid. So for children who are less than 5 years, for them bi-weekly supplementation is given. A child is exclusively fed on cow's milk. The deficiency seen is if child is fed on cow's milk, he develops deficiency of iron. So right answer is iron. False 14 number MCQ, false statement regarding folic acid supplementation. Fortified in all wheat products in India, preconceptually given for prevention of neural tube defects. It is present in leafy vegetables, spinach, paneer. Requirements per day in pregnancy is 500 micrograms. The false statement is fortified in all wheat products in India. So folic acid fortification is not done for all wheat products. Daily requirement of iron during pregnancy is, so it is 2.8, and recommended daily allowance during pregnancy is 35 milligrams. So the right option is 2.8 milligrams. In iron deficiency anemia, after hemoglobin level has returned to normal, so that iron stores are replenished, so how long you need to continue? The options are 0 to 3, 3 to 6, 6 to 12, 12 to 24. Here the right option is 0 to 3 months. So continue the prophylaxis for 3 months. Poor source of iron is in green leafy vegetables, jaggery, meat, so it is butter, because milk is poor source, so butter is also poor source of iron. Twin fortified, 18 number MCQ, twin fortified salt contains iodine and fluorine, iodine and calcium, iodine and iron, iodine and chlorine. So now twin fortified salt is available and it contains iodine and iron in it. Dose of albendazole for children between 12 months to 24 months is 100 milligrams, 200 milligrams, 300 milligrams, 400 milligrams. Here the right answer is 200 milligrams. Dose of albendazole for 2 years to 5 years age group is 100 milligram, 200 milligram, 300 milligram, 400 milligram, and the right answer is 400 milligram. So these were the MCQs which appeared in the NEET exam. One more MCQ, that is, anemia is responsible for 20% of maternal deaths. So remember this thing also, 20% of deaths, maternal deaths, are just because of anemia. So that is also important as MCQ point of view. Now this is the emblem for anemia mukt bharat, because nowadays you even get visual questions. So there in visual question you might get this emblem, and this is emblem for anemia mukt bharat. So join hands to make India anemia mukt, or free of anemia. Thank you. Stay home, stay safe.